years old male presented with severe headache and repeated vomiting for about 2 weeks duration. And this is the MRI.
Contrast دكتورة pre and post.
عرفتي الهيستوري بابا عايشة؟
ايه أستاذ؟
11 year. ايه
multi-sequence multiplanar MRI show a well-defined expanded mass seen at the left midbrain. It is low on T1 and on T2 with no contrast enhancement, no diffusion restriction, and causing mild mass effect on the اللي هو prepontine cystine interpedunculaar cystine يعني and optic chiasm. picture تمشي ويا يعني midbrain mass يعني ممكن نعطيها glioma مثلا.
MRS.
It's high on T2 هم يعني تمشي ويا glioma. MRS show high choline. إذا أكو sagittal دكتورة.
لأن الساجيتال هو ال 3D flare.
إذا mid brain lesion بالليفت سايد expensile expanding ميدبرين. شنو تخلين diagnosis provisional diagnosis differential diagnosis بابا؟
يعني أكثر شيء ممكن جلايوما يعني أخليها
بقلايوم.
بس differential diagnosis.
بعد يعني عمره 11 سنة، ممكن غير شيء تخلين غير الجلايوما؟
يعني يعني ممكن demyelination disease.
بس ما يجي بهالشكل، يعني
إيه
يجي
يعني لأنه ماس وديمايلين وإكسبانسنج وهذه.
بالضبط. يعني قصدي acquired congenital ممكن تخلين فد.
لا هي ماس يعني فممكن ميتاستاسيز خليها.
وجلايوما يا تايب هذه مالك قلنا كلين جلايوما البلبرين. عندك فكرة؟
يعني أثروسايتوما مثلا.
مم. بعد بالنسبة للسبكترو شنو اللي شفتي بيه؟ لام ار اس.
ده
هاي
شفت
كولي. هاي كولي.
أكو هاي كولين إيه
أه؟
اللي هي هذه العالية كلش و آم، مدى أشوف صراحة مدى أعرف إنه أكو بها غير شيء ممكن. فمعناته هي هاي جريد.
هاي جريد خليه.
هاي جريد جلايوما إيه.
بعد. اوكي عايشة شكرا.
هلا.
حسناء موجودة ويانا؟ حسناء أحمد.
بي أستاذ.
صباح الخير حسناء.
صح نور أستاذ.
سمعت الهيستوري وسمعت
نعم
الدسكشن.
أستاذ.
your opinion.
عمو تبع ال MRS ما دام عندنا كولين elevated و N acetyl aspartate low فهاي جلايوما.
بعد.
يعني ما يمشي حتى ويا الميتاستاسيس حتى الفيتشرز مالته لأن الميتاستاسيس عادة تكون multiple وبالإضافة لذلك تكون وياها كلش يعني إديمة هواية
بعد.
وما تمشي حتى ويا الانفلاماتوري لأن هي اكسبنسايل.
وش يسوي له هذا؟
هي عمو يعني هي بس ليجن وحدة هي المكان مالته يعني صعب شوية بس هي ممكن سيرجري أو ممكن ستيريوتاكتيك سيرجري يعني إنه يسوي لها راديو سيرجري هيك شي بس المكان مالته هي شوية صعب يعني.
جاما نايف ما يفيدها؟
إيه هو عمو ستيريوتاكتيك.
ستيريوتاكتيك جاما نايف. اكو بي ليميت بالنسبة للسايز الجاما نايف؟
يعني
no patient benefit or not benefit حسب
يعني
علمك شلون؟
هو عمو إنه يسوي له متابعة بعدين بس هو أكيد يعني بي بينفيت.
يعني قصدي اكو upper limit of size of tumor of lesion of brain lesions بانديكيشن للستيريوتاكتيك الجاما نايف والهاي لو ماكو كلها ممكن يسوي لها. ما عندك فكرة. اوكي شكرا حسناء. نرجع على الدكتور احمد. احمد احكي لنا يا ابني على
عادي
الكيس.
دكتور.
العفو اسف.
نعم
احكي لنا
دكتور.
على الكيس وتفضل.
طبعا مثل ما
احكي.
تفضلوا زميلاتي هي well defined expansile mass involving large mass involving the left midbrain measuring about 33 يعني 25 في 25 مليم showing central T2 hypointense T1 isointense and T2 central hypointense with REM enhancement of hyperintensity on T2 and the flare. No remarkable enhancement after IV contrast or no or diffusion restriction. It has an exophytic component to the interpedunculaire cistern involving the tegmentum of the brain and no extension to the tactile plate. Also may have also having a little mild having midline shift to the right about 7 mm. And with the preserved aqueduct patency, no features of hydrocephalus. As we see here, on MRS profile, high choline versus small NAA profile may suggest high grade glioma. So we said for pathological correlation. And another finding after, if you have seen it, multiple area of high signal intensity in T2 involving the both thalamus, the splenium of corpus callosum, the dentate nucleus of the cerebellum. After taking history of the patient have positive family history. His father known as phacomatosis, NF1, multiple neurofibroma, and caffeolate spot. Also, the patient have numerous caffeolate spot all over his body. So we are going in the context of neurofibromatosis type 1, and this is midbrain glioma. And the patient having this FASI, high signal intensity, the FASI, and the patient considered as the midbrain glioma with NF1.
السلام عليكم أستاذ.
عليكم السلام. منو؟
أنا أحمد خلف دكتور. أسأل
يبقى مع بعض، خلينا نخلص هاي الكيس وده هاي.
إن شاء الله أستاذ.
وعفوا the patient also have lateral deviation of the left pupil, also considering a part of third nerve oculomotor compression or verse infiltration, as you see here, caused by the glioma.
بين. هذه الفايسي ما يصير بها ريستريكشن مو آسا؟
نعم, showing only high signal intensity with no diffusion restriction or يعني enhancement.
بين.
نعم. واحنا يعني ظلينا حقيقة أول شيء محتارين بها الكيس لأنه ما عرفنا الكلينيكال هيستوري as usual إنه هي جتي الكيس إنه فقط headache و vomiting, وبعدين يعني after digging and asking the patient يلا عرفنا. فحبيت أقدمها لأنه يعني إنه نشرح ال CNS manifestation of NF1.
يلا جيد عشتي.
نعم.
نروح على التوك بابا.
نعم. طلع الأستاذ؟
طلع بلي.
نعم. This is the report. This is our patient, has multiple cafe au lait spot, and this is our report. My presentation today is CNS manifestation of neurofibromatosis type 1. Me, Asar Basel, fourth year trainee of Iraqi Board Diagnostic Radiology. Introduction about neurofibromatosis. Type 1 and type 2 are distinct genetic disorder caused by mutation in different gene, resulting in different tumors and symptoms. NF1 caused by mutation in chromosome 17, primary cause skin changes and peripheral nerve tumors, early childhood presentation, and it is considered more common, about 1 in 3,000 to 5,000 cases. And NF2 mutation in chromosome 22 causes tumor on the hearing balance nerve and the spinal cord, often diagnosed later. It is considered rarer, about 1 in 50,000. Genetically, both are autosomal dominant. NF1, also caused known as von Recklinghausen disease, is a multisystemic neurocutaneous disorder. The most common phacomatosis. It's also one of the most common inherited CNS disorder and inherited tumor syndromes. Diagnostic criteria of NF1 is the presence of 2 or more of the seventh. This is the seventh clinical presentation, which are the cafe au lait spot, axillary inguinal freckling, multiple cutaneous neurofibroma, nodules, hematoma of the iris, sphenoid wing dysplasia, positive family history, and also the optic glioma, or the presence of the positive genetic test. Neurofibromatosis CNS manifestation is our concern today. As we said, it is complex, multisystemic disease, broad range of expression and unpredictable behavior. The cognitive disability is the commonest neurological symptoms, especially in children. It is a broad spectrum neurological symptoms and CNS tumor. Many tumors are asymptomatic, but visual disturbance, precocious puberty, acute hemiplegia, focal neurological deficit may manifest. Also, multiple sclerosis and epilepsy have association with neurofibromatosis type 1. Neoplasm, as a result of inactivation of a tumor suppressor gene, NF1 is also associated with increased incidence of numerous tumors, particularly for CNS. The most common here neurofibroma, which are benign, grade 1 WHO, peripheral nerve sheath tumor, has strong association with neurofibromatosis, particularly the plexiform neurofibroma, which is considered pathognomonic for NF1. It has a risk of developing malignant peripheral nerve sheath tumor in about 10%. Clinically, the plexiform neurofibroma present as subcutaneous mass. They feel like bag of worm. On MRI, it's hypointense on T1 and hyperintense plus the central hypointense focus, they call the target sign. It has mild enhancement after IV contrast. Other neoplasm, the glioma, seen about 20% of cases in NF1. In juvenile pilocytic astrocytoma, here most common glioma associated with NF1, presented as optic nerve and pathway glioma. Here most common CNS manifestation, or less likely diffuse brainstem glioma, which has better prognosis and usually low grade in context of NF1. Spinal astrocytoma and spinal pilocytic astrocytoma also present. The other neoplasm is ganglioglioma, extremely rare, typically low grade CNS, often rising below spinal cord. Now we are talking about the radiographic features of the CNS manifestation, اللي commonly present as focal area of signal intensity, هي الفاسي. هي bright area on T2 image, commonly identified in the basal ganglia, often the globus pallidus, thalamus, brainstem, البونز, الcerebellum. Subcortical white matter present about in 86 to 100% of children with NF1, strongly associated with cognitive impairment. On MRI, BT1 here iso-intense to hyper-intense, T2 flare hyper-intense as we see it in our case. After IV contrast, no enhancement, no mass effect. Sometimes, some cases have reported to have enhancement and mass effect, so it's difficult to differentiate it from low-grade glioma. الMR spectro normal. عفوا. Optic nerve, optic pathway glioma اللي هي typically present in children, accounting for 10 to 15% of supratentorial tumor in the age in this age group, and are often the setting of NF1 about 10 to 63%. The tumor here low grade and indolent, male and female approximately equally affected. Clinically presented in decreased vision, about 63%, and mass effect also with the proptosis. Involvement of the hypothalamus may result in polyuria, polydipsia, obesity, sexual precocity, endocrine dysfunction, like short stature. And when large intracranial tumor maybe have raised intracranial pressure, focal neurological deficit, hydrocephalus may be seen. On CT scan, the first investigation modality, enlargement of the optic nerve, and mass may be either fusiform or exophytic in appearance. Enlargement of optic canal, optic nerve may be elongated with kinking and buckling. On MRI, large tumor typically heterogeneous with cystic and solid component. T1 راح تكون iso to hypo intensity compared to the contralateral side. والفلير راح نشوفه hyper intense centrally, low low signal on the periphery representing the dura as we see here. After IV contrast, enhancement is variable as we see here in multiple sequence. أن البروجريسيف سفينويد وينج ديسبليجيا هي seen 5 إلى 10% من الكيسز of NF1 and one of the diagnostic criteria. Also seen in isolated cases. Pulsatile exophthalmos is the most frequent presenting complaint. It's assessed by either CT or MRI. Hypoplastic or absent sphenoid wing resulting in widening of the superior orbital fissure, elevation of the lesser sphenoid wing, and ipsilateral orbital enlargement. عندنا gapping bony defect in the posterior aspect of the orbit. احنا ممكن نشوفه. Absence of innominate line on the plane radiograph on CT scan giving the bare orbit sign. Also, it lead to expansion of the middle cranial fossa, herniation of the dura, peritemporal subarachnoid space, the temporal or frontal lobe into the posterior aspect of the orbit, causing anterior displacement of the orbital content, with sphenoid wing dysplasia associated with neurofibromas, usually. As we see here in this case, 45 years old male with NF1, we see well-defined defect at the right sphenoid, allowing the the inferior right frontal lobe to herniate to the orbital right orbit. Note that the absence of the lesser wing sphenoid line in the right orbit as compared with the left side, the responsible for the bare orbit sign. Other case, also multiple MRI image showing sphenoid wing dysplasia, as we see here, right orbital, also right orbital plexiform neurofibroma, cavernous sinus mass, could be plexiform neurofibroma, schwannoma, or less likely meningioma in patient with NF1. This is the sphenoid wing dysplasia. Also, we can see it with comparing to the left side. We have thinning of the bone. Also, another manifestation here, dural calcification at the vertex. About 1% of patients with NF1 presented with neural calcification as nodular type or sheet-like presenting. Another, the lambdoid suture defects in about 50% of patients have a skeletal manifestation of NF1, as we see here, sagittal CT and the X-ray lateral view. Another manifestation is the dural ectasia. It refers to ballooning or widening of dural sac, which can result in posterior vertebral scalloping and is associated with herniation of nerve root. It is common and often asymptomatic, affect about up to 70 to 80% of cases of NF1. It may be presented with low back pain, radicular pain of the legs, leg weakness, urinary incontinence, also association with the spondylolisthesis, scoliosis, vertebral erosion, and vertebral fracture. There is also an increased incidence of anterior sacral meningoceles, which may be present as abdominal mass. In radiographic feature, البلاin radiograph راح نشوف posterior vertebral scalloping on lateral radiograph. والMRI راح نشوف أيضا anterior posterior diameter increasing. Also the posterior scalloping also present. Moyamoya syndrome, also considered as a CNS manifestation, although it is rare, it is progressive pediatric vasculopathy presenting as bilateral or unilateral stenosis of the distal internal carotid arteries. It's a progression initially unilateral up to 30% of cases, but high risk of progression to bilateral disease. Radiological feature هي الفيزل راح نشوف stenosis narrowing or occlusion of the terminal internal carotid artery, proximal middle cerebral artery and anterior cerebral artery. وراح نشوف collateral vessel اللي هي multiple small tortuous flow void in the basal ganglia and thalamus called the moya vessels. IV sign اللي هي high signal intensity in the cell side on flare imaging due to slow flowing engorged PL vessels correlating the disease severity. Also ischemia often show prior cortical strokes, watershed infarction, or atrophy on T2 flare. As we see here, the sagittal T2 multiple flow void tortuous channel are seen بالperiventricular region والاxial والsagittal MRA demonstrate اللي هي complete occlusion of the supraclinoid ICA on both sides and non-visualization of MCA or ACA on both sides with multiple collateral channel in keeping with moyamoya disease. This angiogram showing the extensive perforator and collateral اللي هي puff of smoke. Lastly, the puff of thalamus اللي هي neurofibromatosis is rare, about 1 to 2%, but severe manifestation representing congenital or infantile glaucoma due to orbitofacial plexiform neurofibroma infiltration. شلون راح نشوفها؟ راح نشوف unilateral diffuse enlargement of the ocular globe, often associated with sphenoid wing dysplasia and proptosis. As we see here in this 5-year-old girl with NF1 and proptosis, axial fat suppression T2 reveal احنا عندنا enlargement of the right globe consisted with buff of thalamus اللي هي right sphenoid bone dysplasia عندنا هنا و associated enlargement of the right middle cranial fossa, plexiform neurofibroma, bilateral aspect of the orbit, and also nerve sheath tumor within the right cavernous sinus nickel cave. And thank you very much for your listening. This is my reference, and thank you.